All right. Hello, everybody. So glad you're here. This presentation tonight is about, like you see here, pulling apart ADHD and trauma in the brain. So it's a really complex, big topic to try to do in an hour and a half, and we're going to get through as much as I can. So this is me. I try to be cognizant of people that have neurological differences, and if you do better listening or reading, so I just try to read through the slides and then also talk throughout. So I've been a counselor for over a decade, primarily working in social services with children, women, and families. The areas that I specialize in are trauma-informed care, neurodivergence, newborns and postpartum mood disorders, and moms. I have worked with thousands of foster kids and kids in general that have trauma and ADHD, and I'm so glad that all of you are here. So tonight we're going to be talking about what is ADHD, how to diagnose it, what is trauma, how to identify it, how to navigate both things in the school systems, how to get support at home, what does a multi-systems approach look like with ADHD and trauma, and then a really good list of resources at the end. So, what is ADHD? ADHD stands for Attention Deficit Hyperactive Disorder. Formerly, it was called ADD, but today in 2024, it's accepted to be known as ADHD. It's a neurological disorder. I also like to use neurological difference. One of the most prevalent childhood disorders is ADHD. As of last year, 2023, 6 million kids have been diagnosed, with those numbers significantly rising, and they're attributing that to more awareness around ADHD, more providers that are able to identify and diagnose. And we'll get into some more finite details of that later on. ADHD is a hereditary neurological disorder, meaning if you have parent or a family member, you have increased chances of having it. Some of the more recent research also supports that if there's substance abuse in utero when a mother is pregnant, that can also cause ADHD. ADHD affects the prefrontal cortex. It causes a pretty significant difference in someone's function. Your prefrontal cortex is right under where your forehead is. Your prefrontal cortex is responsible for your reasoning, judgment, self-control, and there's a range in severity with ADHD from mild, moderate to severe, and that's typical with most neurological differences. So I wanted to break up the symptoms of ADHD by gender because they can present very differently, and this is looking at children and adolescent youth. So if we're looking at the girls, and I want to first highlight this part at the bottom, girls are less likely to be diagnosed in childhood because they tend to internalize their symptoms a lot better, and you'll see that as we start to compare and contrast these two lists of symptoms. But typically, we are going to see in girls anxiety, academic underachievement, making more careless mistakes at home and in the schools, having a harder time paying attention, zoning out when you're speaking to them. So they're there, but then 2 minutes later, they're like, what did you say? Or you'll ask them to repeat back or to respond to what you said, and they did not hear what you said. So that's what I mean when I say zoning out. Not following through on chores, schoolwork, commands, tasks, having difficulty with organization. So for a child, what that's going to look like is not being able to keep all their school paperwork organized. It's maybe scrunched at the bottom of the backpack. Having a hard keeping track of where they left things, losing things often, organizing their thoughts. So how they're presenting something to you can be disorganized. with their thoughts kind of bouncing all over the place. Poor time management, and that oftentimes looks like time blindness, where there's just a complete lack of awareness of time, which is developmentally appropriate for younger kids. But as kids get to a point where they can start to read a clock and have a general internal idea of what time looks like, kids with ADHD really struggle with that. There's avoidance of tasks that requires focus, and so they'll put something off, put something off, put something off, because that focus is really challenging for them. Losing things often, that's tied into that organization piece. Easily distracted, forgetting things often, no matter how important it is. That piece is really important to remember, that it is not associated with importance, how often these kids are forgetting things. It's just a component of the ADHD. And then lastly, for the girls, they're internalizing emotions quite a bit, which is leading to low self-esteem, low self-image. And so they're masking quite a bit of this as much as they can. If we'll get into when you can diagnose someone, but they do try to mask as much of this as they can, which is again why it's harder to diagnose the girls. And then we look at primary diagnostic symptoms of boys. Some overlap, some different. They tend to be more fidgety, do a lot of tapping, a lot of squirming in their seat, difficult time staying still in general, having a hard time waiting their turn, interrupting everyday activities or conversations, taking over something without permission, kind of combined with waiting their turn. But if someone's doing something, they're just gonna like interject and take over and not ask permission. And even if the person says no and they ask, they're gonna do it anyways. They're not gonna wait for that response. It's a real lack of impulse control. Blurting out rather than waiting their turn. So rather than raising their hand and asking for the teacher to call on them, they're just going to shout the answer out. Careless mistakes that happen in all areas of their life. Difficulty staying seated. So a little bit different than like the squirming piece. It's they can really struggle with actually keeping their bottoms in the seat and seated. Being really forgetful, again, no matter the importance. Again, difficulty with organization, constantly on the go, just busy, busy, busy bodies. Inability to play quietly unless they're hyper-focused, and we'll get into in a little bit what that means. So they do have the ability to play quietly, but typically under very specific circumstances that can't be controlled by external people. Talking excessively, just talking. Then their behaviors tend to be more externalized, can look like aggression, antisocial, getting into fights. So you can see a lot of this is more behavioral than what we see in the girls. And so it's easier to see the behavior and then start to wonder, I wonder if there's something behind this. So in order to diagnose a child with ADHD, according to the DSM-5, which is what doctors, psychologists, psychiatrists, neuropsychologists use to diagnose a disorder, a child has to have at least 6 symptoms from like that list I just showed you. Has to start by the age of 12, although we can start to see symptoms as early as the toddler years. However, typically someone isn't going to diagnose a child with ADHD until they're 4, just looking for some patterns or looking for some other root causes of those behaviors. The behaviors have to, or the symptoms have to last at least 6 months. And then it has to be identified that it's causing problems in the child's function at home, at school, or with their peers. So other symptoms of ADHD with boys and girls are they have a different processing speed. And so your processing speed is how quickly you can absorb information and then respond with your thoughts and your feedback. So oftentimes what we'll see with people in general that have neurological differences, but also specifically ADHD, is that processing speed can be different. And so what that looks like in presentation with kids is if they have a slower processing speed, is you'll say something to them, you'll give a command, please go pick up your shoes. And then they'll kind of look at you. And you're thinking like, they're looking at me. I know they heard me, but they're just kind of, there's a slower, it takes longer for them to process that thought and then act. And then in school, what that might look like is if they're given a several step activity to do, they might only be able to retain those first couple steps because that processing speed is slower. They need things broken down for them. As adults, what that looks like is someone that understands they have a slower processing speed might say, I need 5 minutes to think about that. Or can you give me the assignment tonight for work? So I have the evening to think about it so I can give you an answer tomorrow. So they just need more time and they're able to articulate that. Kids don't typically have that ability. Another common symptom with ADHD is hyperfocusing. Almost, I don't know anyone actually that has ADHD that doesn't do this. Hyperfocusing is when they get, it seems like almost obsessed with something and they can hold their attention for a long period of time. And so what can often happen with caregivers is you think, look, I know you can pay attention. I know you can sit still. You do it when you're playing your Legos, or you do it when you're playing your video games, or you do it when you're doing your 3D printer. They can if they're hyper-focused on something. And it is not a choice what they become hyper-focused on. And that hyper-focus does not last long term. It's situational, circumstantial for a period of time, and then they move on to hyper focusing on something else. Something else that's really common with boys and girls that have ADHD is having sleep problems, having a hard time falling asleep, especially if they have anxiety, which many people that have ADHD do also have anxiety. So hard time falling asleep, hard time staying asleep, not sleeping well, just sleeping very restlessly. And then tiredness, that can be from sleep problems, but it can also just be from the way that they function, the way that their brain works is exhausting for them. We do not live in a world that's built for neurologically diverse children. And so it is exhausting for them to have to function the way that they do. And so tiredness, no matter how much sleep they get, can be a very common symptom of ADHD. Another one is stemming, and this is often associated with autism, but it's actually common for people that have ADHD to stem. And what stemming looks like is a repetition of a behavior or a sound. So one example of stemming might be like if a kid likes to go and they just do it over and over and over and in different ways, different levels of noise. So this is not repetition, and they usually cycle through different noises or behaviors that they will stem. It's usually used from kids to create stimulation if they're lacking stimulation, or used to as kind of an outlet if they're overstimulated. It can be used both ways. Echolalia is similar to stemming, but it's just specific to sounds that kids make. So they'll just hear a sound and then they'll repeat it over and over and over and over and over and over. So I'm trying to think of an example. So there's a bird called a Swanson's thrush that goes wee, 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 wee. And so a child with ADHD might hear that sound and then repeat that sound over and over and over. It's similar to the stemming in that it can be sensory output, and it can also be something that is calming for them to give them, provide them with stimulation and also help reduce overflow of stimulation. So it's really important to remember with the stemming and the echo that these aren't choices that kids make. It can feel really frustrating and overwhelming as the caregiver of kids that are making these noises, these sounds, these behaviors repeatedly. It can feel really frustrating. Like, I told you not to make that noise, or I told you to do that outside. It happens mindlessly. They're not thinking of doing it. They're not doing it typically to irritate you. It's something that their body is telling them they need to do for sensory output or some kind of release. So doesn't mean it's not frustrating, but just try to keep in mind it's never intended to annoy you. It's just a piece of the ADHD. So I'm curious to hear if anyone's surprised that there's differences between the boys and girls and how the symptoms present. Or if you're surprised that there's similarities too, because there definitely are some that overlap. Nope. Someone said not surprised. Good.
I can speak for myself
Yeah.
and that I was diagnosed with ADHD at 52 and I had all those symptoms as a young girl and nobody ever caught it. My brother had ADHD, his was caught because um he showed differently
Yeah.
than myself, and it just kind of seemed like I had a learning disability, and that wasn't really what the case was. More or less,
Hmm.
I learned differently than other children.
Yeah. Yeah, that's great that you have that insight from your childhood and now you have a name for it. I imagine that was maybe a relief for you to get that diagnosis, to just understand.
Absolutely. Yeah. It just allowed a little more forgiveness to myself for what I considered shortcomings.
Hmm. I love to say that people who are neurologically diverse have superpowers because I'm neurologically diverse and I know that our brains work differently than neurotypical people. And I just think there's so many beautiful superpowers that can come with that. And actually, adult women, um, in adulthood, women are the ones that are the most commonly diagnosed more than men. Someone said that in their family, only boys have it. Is ADHD found in the bloodstream? That's a great question. No, you cannot diagnose it through the blood. We'll talk about how to diagnose it. All right. So then we're going to get into how do we diagnose? So it can be diagnosed in a pediatrician's office by just the pediatrician evaluating symptoms. I've worked in social services for 17 years, and in up until, gosh, I would say the last 5 to 7 years, that's predominantly how I would see kids, foster kids, being diagnosed is just by the pediatrician. Um, Also, a psychologist, a psychiatrist, a neuropsychologist can diagnose. They will do a more thorough evaluation. They will get feedback from the caregivers, from the teachers, and the child. If the child is over 6 years old, sometimes they'll wait until 8. They'll do what's called a BASC-3, and that's an evaluation that's used, a self-evaluation teacher and caregiver evaluation to look at the different symptoms and how they're presenting in all of those different environments. Um, when any of these people, the psychologist, psychiatrist, or neuropsychologist are doing an evaluation, they're going to also assess for other co-occurring disorders or contributing factors for the symptoms that the child is having before they're diagnosed, the reason for the evaluation. It's important, that's important because there are other things that can mask as ADHD. So sleep disorders can present very similarly to ADHD. And so these doctors up here are going to get as much as they can a good background on the sleep quality. They might even request a sleep study before an evaluation. Substance abuse or substance abuse withdrawal can also present as ADHD. Medication for other diagnoses can present as ADHD. If there's environmental changes, if a child moves to a new home, removed from their home, if a child moves to a new school, significant environmental changes can mask as ADHD, so can trauma that can almost identically mimic ADHD. And then also undetected learning disabilities. So this is why it's important to get a diagnosis from someone who will do a full comprehensive evaluation. And so the pediatrician's office is a great start. And then you really want to try to advocate with a social worker for getting a more formal diagnosis. And we'll talk later on about how to do that. So it's not uncommon if someone has one neurological disorder that will have others that impact overall function. If you have one, you tend to have another one. If you only get the ADHD diagnosed but not other co-occurring disorders, you're not treating the whole child. and you may not see the improvement you're looking for because there's other things going on that you don't yet know about. So that's why it's important to get a full comprehensive evaluation. And other common neurological disorders are dyslexia, which is a learning disorder that affects writing and can affect reading. Dysgraphia is a learning disorder that affects fine motor skills. Dyscalculia is a learning disorder that affects the numbers and arithmetic. And then sensory processing disorder, autism, and IQ differences are also common neurological disorders. There's other ones, those are just the most common ones that are evaluated during a full comprehensive evaluation. And when I say IQ differences, I mean a lower IQ or a superior above average IQ, both of which can really affect a person's function. And it is common to see someone that's neurologically diverse to have these diagnoses and then also an IQ difference. So it's also not uncommon for anxiety and or depression to be co-occurring, which can also be identified during a full comprehensive evaluation. Anxiety, especially in younger boys, can present as agitation, irritation, hostility, all of these like more angering type emotions. It can exacerbate the ADHD, but also it can be easily masked. Like it might not what you think anxiety might look like. So it's important to get someone evaluated for that. If you have a child in your care that is diagnosed, it's really important to keep documentation of that, and I'll talk a little bit about why. And then you want to make sure you have documentation to provide to the social worker. When you're getting ready to get this evaluation done, keep really good documentation of concern so that when it's time to fill out those questionnaires, you can easily and readily share that information during the evaluation process. So I'd love to hear if anyone here is familiar with any other neurological differences that their child has along with ADHD, or maybe personal history with that or experience.
We have a child that has that is ADHD but also has sensory processing disorder, and we believe anxiety, a certain level of anxiety, and the sensory processing disorder, I think, is definitely it's a different level than the ADHD symptoms that you're talking about.
Thank you for sharing that. Yeah, all of these things have a range, and depending on where they're at in their range with their different diagnoses, one can impact their function more or less than another. Sensory processing disorder is certainly something that can really affect a child's function. Another one I don't have on here that's a really common co-occurring disorder with ADHD is oppositional defiance disorder. Someone shared that my boy has rated extremely high in his IQ test, 99th percentile on IQ. Yeah, so that's a neurological difference. That could potentially qualify a child for an IEP. We'll talk later on how and why that would look like. But that's really, really important information for you to have. I'm glad you have that information. I had another thought, but I lost it. Okay. So then we want to look at trauma because these present so similarly. So common symptoms of trauma: disorganization, difficulty with sleep, poor impulse control, inattention, difficulty paying attention. And these are a little different. Like inattention is they're just not paying attention. It's just not happening. And then difficulty is they're paying attention, then they lose it. They pay attention, then they lose it. Easily distracted, kind of similar here. Can be a little bit different though. Difficulty with chores, homework. Focus is a huge piece. Or lack of focus, I would say. Easily agitated, emotional dysregulation, Emotional outbursts is agitation, fights, mood swings, or apathy towards things or people, difficulty focusing, and then other co-occurring disorders of trauma we typically see in kids are anxiety, depression, sleep disorders, and then reactive attachment disorder, commonly known as RAD. So, how similar is this list to these lists? I mean, they're so similar, right? This is where it gets really tricky. Who diagnoses trauma? Typically, a therapist or a professional, a trained professional working with a child can identify trauma. It's not actually something that we diagnose, but it's a noun used to describe how a child presents. So if someone, a professional working with a child, is noticing all of these things and they know that there's a trauma history there, they're going to probably identify that this child has trauma because of the history. However, there is PTSD, post-traumatic stress disorder, which is a diagnosis in the DSM-5, and it's under trauma and stress-related disorders. That's different and the same, a little bit nuanced. But this is an actual diagnosis, whereas a child that has trauma is not a diagnosis. Does anyone have any other symptoms of trauma that they've observed in their child? I know this is absolutely not a full comprehensive list. I know that there's a lot more if you guys want to share.
Yeah, so this is EC and our kiddo, well, what we've sort of seen is that I think is kind of different from ADHD is the ability to sort of be triggered by certain things that kind of trigger you know, a response based on what he's been through. So I was wondering if that was maybe one of the differences. And it's a really like extreme overreaction to certain things that are pretty minor.
Do you see a pattern with what the thing is that they react to?
I don't know if it's a pattern as much, and I think we're really here because we can't disentangle the ADHD from the trauma.
Mhm.
But you know, anything that sort of invokes that, you know, I think for him what's been
Abandonment.
hardest is that you know, neglect and abandonment. So anything that kind of makes him feel like he's not getting what he needs, it tends to have a really, really strong response that lasts for a really long time.
Yeah. Yeah. So I just want to validate that it's really hard to pull apart ADHD and trauma. That's why I wanted to do this presentation. It's really hard. They present so similarly, and a lot of times we treat them the same. And when I say we, I mean professionals that work with children to treat them or support the parents to treat the child, support the parents to support the child. Sometimes you cannot pull it apart, so to speak, but you can start to look for things. And the reason you can't pull it apart, like with your example, is poor impulse control and easily agitated emotional dysregulation. Those are some prime classic symptoms of ADHD. Something else to note too that I didn't mention earlier in one of the first couple slides about things that are kind of precursors to ADHD, I had mentioned if there's a family history of it, if there was potential substance abuse while the baby was in utero. Another precursor also can be if there's trauma early on in childhood. Trauma early on in childhood can lead to ADHD, but it's also that question of did the chicken come before the egg? Because how do you know for sure they wouldn't have ADHD if they hadn't had the trauma? And there's no way to know. But we do know that trauma is a precursor and they present very similarly. So one of the things you can do is look for, is there patterns of things that cause that reaction? And if there is that somehow connected to the specific trauma? If it carries on long term, I would say that has more to do with trauma than the ADHD. Typically, unless they're hyper focused on something, they're going to let it go pretty quickly. I hope that's helpful.
I have a
What
question.
yeah,
So, my question is this related to trauma or is it ADHD or is it both?
yeah, we're covering
So,
both.
well, no, for my kiddo,
Okay.
because when he does something wrong, I will send him upstairs to his room to sit in there, and when he does go upstairs, he screams, pout, even louder. Like,
Mhm.
what is that? Is that both? Like he'll scream in his room and pout, like no, just and I just be trying to figure out what is that? Why does he do this?
I'm hoping the next couple slides will help you answer that, but if they don't, I want to make sure to check back with you and answer that directly.
Thank
So
you.
yeah, yep. Um, someone else had a comment in the chat section. What qualifies as trauma, physical and verbal? Um, it doesn't have to be both. Like it can be how they present. Like some kids don't have the language yet to verbally express what happened to them, but they clearly have behaviors of trauma. So a child that's 2 or 3 or 4 or 5, they might not be able to actually articulate. They don't have the words to say it, but you're going to see a lot of these behaviors. Or there's some kids who become mute for a period of time. It was so traumatic they can't speak, so you're missing that verbal piece, but you can still diagnose or not diagnose, identify trauma or diagnose PTSD because of the behaviors that you're seeing. So here's some more language around signs and symptoms of trauma and what it looks like based on the age of the child. And this really gets a little bit more specific to the trauma. And these examples are not as easily identified as ADHD. So I'll just give you guys a minute to look through those. I'll read some of them. For preschool children, fear of being separated from parent, crying, whimpering, screaming, immobility and or aimless motion, trembling, excessive clinging, frightened facial expressions, regressed behaviors like thumb sucking, bedwetting, fear of darkness, self-soothing like rocking, head banging. So to the person who asked, is it physical and verbal? You can see here that a lot of these are nonverbal. Elementary school children, extreme withdrawal, disruptive behavior, inability to pay attention, regressed behaviors, nightmares, sleep problems, irrational fears, irritability, school refusal, anger outbursts, fighting, poor academic engagement, depression, anxiety, feelings of guilt, emotional numbing. Almost all of these could be attributed to ADHD as well. Yeah. And then middle and high school children, flashbacks, nightmares, sleep problems, emotional numbing, avoidance of reminders, depression, substance abuse, antisocial behavior, withdrawal, isolation, physical complaints, suicide ideation, school problems, confusion, and guilt. I would say half of these can be associated, attributed to ADHD, but not all of them. We're not going to get into it tonight, but ADHD is a huge precursor to substance abuse as a way to cope with their function. And typically the co-occurring disorders of depression and or anxiety that go along with ADHD. So you can see how this is it's really fluid. Like the ADHD and trauma just really flow together and look the same and present very similarly. And therefore treating or supporting children with either can look very much the same. And then we want to look at PTSD, just clearly identify that, a different subset of trauma. So diagnostic criteria cannot often identify it in babies and young children, although trauma can definitely be very clearly identified in babies and young children. In babies, what we're going to see is that flat affect. They don't cry for their needs. They don't make eye contact. They are just, it's like a soulless human being. I've seen babies severely neglected and abused, and all I can say is that they seem as though they have no soul. They don't cry for their needs. So then you can very clearly identify that that baby has been traumatized. The symptoms can begin days, weeks, or years after the traumatic event or events to be diagnosed and start experiencing PTSD. Stress effects last months or years after event or events. It is not an acute response. So acute is like immediate. Effects must last longer than 6 weeks. So anything beyond that 6-week point is no longer considered acute after the event or the event has occurred in order for someone to be diagnosed with PTSD. Someone with PTSD can and will have the same signs of trauma, but also include more intrusive thoughts, flashbacks, strong somatic response, which is just how your emotions present in your body, such as shaking, sweating, racing heart. Nightmares, night terrors are also a really common indicator of PTSD, and then fear avoidance, whatever the triggering event is that reminds them of the event or events. So to just differentiate that a little bit. So this pictorial gives a really good example of how the trauma and the ADHD present differently, but then how they can overlap and present very similarly, and why it can be really hard to pull it apart. The overlap is what I want to focus on here, the difficulty concentrating and learning in school, because their brain is in that fight or flight place. So ADHD, or excuse me, easily distracted is one that you're going to see either way. Often doesn't seem to listen. You're going to see either way. Disorganization, hyperactivity, restlessness, and difficulty sleeping. If someone has trauma and ADHD, they have a higher chance of having more on the moderate to severe side of ADHD. And so these things are going to be even more extreme. So knowing where your child's diagnosis came from. So the one thing I have seen often over the years is kids have a diagnosis, and then when I go to get, can you help me? Where did this diagnosis come from? Who diagnosed it? At what age? There's no paper trail of it. There's no way for the caregiver to know how long if they've had it, how they got diagnosed, which can be really prohibitive for the child, not only to get supporting documentation for the schools, but it can also be a huge disservice to the child if that documentation was put in their file as ADHD because some social worker said he acts like he has ADHD, but really it's actually maybe something else. You're missing the mark. You're missing the opportunity to support that child in the way that they need. And so that's just something to keep in mind. Just be asking that question. If they came to you diagnosed, make sure you're aware of how that diagnosis came to play and how long and when, what age. I would love to hear from all of you if you have a child in your care who has been diagnosed with ADHD or honestly like any neurodivergence. Do you know how they got diagnosed and at what age?
So this is EC again. In our case, our kiddo was with a previous foster family who had started the process of seeing a neurodevelopmentalist and then so we sort of carried that on, but we're a little bit confused at the first, at first about like what the process was. And then eventually after, I think it was at least, he'd been seeing her for probably like a year or two. Then, we filled out some surveys and the teachers filled out surveys, and then she wrote us a letter saying that his symptoms and behaviors were consistent with a diagnosis of ADHD, which I thought was really carefully worded. So, I mean, the schools then acted upon it. I'm assuming that is a diagnosis, but I'm not really entirely sure. But it was, from someone who is able to diagnose ADHD at least, and went through the whole process.
Hmm. Well, good for you for finishing that process. And I appreciate the language that that provider used because trauma and ADHD present so similarly. And if we think about how many kids in care do we think have trauma? It would almost be safe to say 100% of them, right? So I appreciate that language. And as long as you have some supported documentation, typically the schools do a great job of trying to provide that support. So there's a few comments in the chat section. Someone says, self-harm as, oh, I don't know what that question. Oh, maybe other indicators of trauma. Yep, absolutely. Especially in the teens. Someone said, I don't have any kids diagnosed with it. I'm assuming ADHD, but sometimes I wonder. Yeah, so let me just mention really quickly, if you are wondering what's the process to seeking an evaluation. So you take them to the PCP, ask for a referral for someone who can do a full comprehensive evaluation, and then getting the social worker's permission to move forward with that evaluation. That's how you start that process.
This is Sue. One of the things that I want to remind, so I was diagnosed as an adult and I had the test done and they sent the forms to my husband to fill out about me. And then I didn't do anything with that for 5 years. And so when I went back to see a provider for medication, they no longer had records of my diagnosis. So it's good to always, like you said, make sure you keep track of where this was diagnosed and keep copies of that stuff, because you may not be able to go back to the place where it was diagnosed. In my case, the company was sold to another company and records, I guess, were lost.
Sue, I so appreciate that share. Thank you so much. Yes, I know for me as a counselor, my WAC regarding how long I have to retain documentation of clients I've seen in counseling is 5 years, and anything after 5 years, I can dispose of those records. So that 5-year mark is pretty crucial to make sure you have that documentation. It's also important for the child to have record of that for when they're an adult. Because if you have diagnoses that impact your function in the learning setting as a child, when you become an adult, you can still use that diagnosis to have a 504 like in college, or to get accommodations at your place of work through the American Disabilities Act. But they typically do need that documentation. And so if you're working with a child that got a diagnosis at 12, I mean, who knows how long you'll have that child, but hopefully you can get that to the social worker, and the social worker will keep that document safe and sound so that when the child is out of dependency care, they will have access to that for when they're older. So thank you so much for mentioning that. Okay, I want to come back to someone's question about when there's things that upset their child and then it carries on long term. Who was that? So Soloma, was that you that asked that question?
Yes.
Did that help at all? And if not, reframe your question again so I can make sure to answer it.
It does help by reading it, but I'm looking for how I can help it. As far as my child,
Okay.
how I can help him. What are some of the things I can do to help him to lead away from doing the things that he does, which is go upstairs and start screaming louder than he was, and pouting and kicking and stomping.
Has he been diagnosed with ADHD?
No, so I'm in the process of having him get evaluated.
Okay.
And so, I don't know anything yet, but he definitely has, from looking at your slideshow here, your presentation.
Okay.
This is
I'm glad.
Sue. So have you read The Connected Child? Because that deals with a lot of that in there. And one of the things that they suggested was not to send a child that's been neglected away from you. Don't send them to their room. Actually invite or have them come sit next to you or sit where you guys have contact or eye contact, which is what we do with my kiddo when he's with us. That seems to work way better at disarming my child.
That's actually pretty good too. I have been trying that as well, and it does seem to work better than sending him up to his room. And we also do breathing exercises too, so that way he's continually to be or continuously being here around the area I'm in, so he doesn't feel that way. But yeah, that is definitely what I've been doing.
Yeah, I like that. I like that tip, Sue. Thank you. We're gonna have some resources at the end that I think will give you some more ideas for support for your child.
I was going to say the Connected Child Cares they do all the books in book clubs and support groups. So check through where you registered for this class. You can look that up, TBRI, the Connected Child, and you'll find all those trainings that you can be a part of.
TBRI is such a good training for children with trauma, just understanding how trauma affects function. I 10 out of 10 recommend the TBRI trainings for anyone. Okay, so moving on, then we want to look at how does ADHD and trauma impact school function? So trouble focusing and paying attention, check, check. Easy dysregulation, check, check. Impulsive, check, check. Struggles academically, check, check. That's just some of them that overlap. There's a lot more. So they present very similarly. This affect their school function. Can anyone think of any other ways that they know ADHD and or trauma affects their child's function at school? Social interactions. Yeah, a lot of times kids with ADHD and trauma both will struggle with social interactions. They'll have a harder time. They can have a harder time making friends. The impulse control, less kids will like them. They may be more withdrawn. Harder time making friendships. Absolutely. Yeah, and pretty much from here on out, I'm going to be parallel. We're talking about ADHD and trauma. Because the support really looks the exact same in school and at the home. Bullying and being bullied. Yep, we definitely see that in the schools, unfortunately, for both. Yeah. So here's some ways we can help at school. So meet with the educators frequently and have consistent communication. Typically, you're going to want to double what the school conferences are. So if school conferences are twice a year, at a minimum, you're going to be meeting with the school 4 times a year. There's just the reality is they need more support and check-ins with the educators. Know who your child's education team is. So their teacher, their school counselor, the school psychologist, the principal, the district special education director, if they have a 504 or IEP, and then the district foster parent school liaison. You can find out who your school liaison is by going to OSPI, the website. Identify if your child qualifies for a 504 plan or IEP if they have one, making sure that you have an actual copy of that, and then becoming really familiar with it so that you can advocate for them. Do not assume that the school will follow the 504 or the IEP. More often than not, I see that the schools are not providing adequate support for these kids, unfortunately. And a 504 and an IEP are not always intuitive documents. It does take little bit of studying essentially to really understand the verbiage and what it means for your child in the classroom. Treehouse also offers educational advocacy and assistance, and CARES has special topic trainings on educational supports every other month in their Education Resource Wednesday events. And we have more information about that at the end. So what things have you guys found that's helpful to support your child in schools when your child has trauma and or ADHD? Is there anything that you found to just be really helpful?
I have a little something. So I have made sure that I have a direct connection with their school counselor and make sure that my kiddo knows that they can go there and talk to them anytime, or even if they just need a moment to themselves, they can sit and usually they have some sort of quiet room or something for them to just have a quiet place to calm down or deal with anxiety.
I love that. That's such an important one because it's important for these kids to know who is the safe person in their environment. So that's a really great one. Thank you for sharing. Next, we're going to talk about what is a 504 plan and what is an IEP in case you're not familiar. So a 504 plan is a blueprint or a plan for how the school provides support for a student with a disability as identified in Section 504 of the Rehabilitation Act of 1973. There is a broader range of who qualifies with the Individuals with Disabilities Education Act, which is what lists the criteria of who qualifies. The two main requirements are a child has a disability, and the disability must interfere with the child's ability to learn in a general education setting. A 504 can include health needs as well. So it can be for asthma, for a food allergy, for a concussion. Lots of other things can be used under a 504 plan. It provides services and changes to a learning environment to support the student's learning. So oftentimes it's going to be just a list of accommodations that that child needs if we're relating it to ADHD and or trauma. So an example might be like the person who just shared about making sure that the child knows who the school counselor is. If a child has a 504 plan for ADHD or for trauma, then maybe an accommodation is if they feel overwhelmed, they can just head down to the counselor's office. They have a special finger gesture they flash to the teacher knows what that means. They silently dismiss them as to not draw attention to the child, and the child can walk themselves down to the counselor's office. That's an example of accommodations that could be on a 504 plan. A 504 plan does not have any specialized instruction outside of the class, so 100% of their time is in the gen ed classroom. There's no requirement for documentation type, who attends the meeting, or reevaluation of the student. So you don't even necessarily need a diagnosis to get a 504 plan, although some school districts require it. It's just based on their presentation and the concerns, and the staff are noticing those same concerns, and it's a document to support them. Examples of people who might be in a 504 meeting are going to be the parent, caregiver, and social worker, and the foster child liaison. The general and special ed teachers. The special ed teachers may potentially be there just to give recommendations for accommodations. They're not there because the child is getting special education services, and the principal will almost always be in these meetings. A social worker's consent is required for the school district to evaluate a child. So a child can be evaluated for an IEP but not qualify, so then they put a 504 plan in place instead to provide some level of support, documented support. Typically, they're going to be reviewed annually. The state does not receive funding for students with a 504, and it can be used, like I said, if a child doesn't qualify for an IEP. I've also seen kids that have an IEP for one thing, they don't qualify for an IEP for all of their needs, so they'll have an IEP for some things and a 504 for other things. Then we want to look at what is an individualized education plan, also known as IEP. When someone has an IEP, they require specialized education services. A lot of times people call it SPED services in order to have equal access to education. There are more limits for who can qualify for an IEP. The disability must affect the child's educational performance and our ability to learn and benefit from general education curriculum. They have to need specialized instruction in order to make progress in school. So the social worker can request outside evaluation provided by the district. So you might find a psychologist, you really want them to do that evaluation rather than the school. So the social worker can put in that request. The district is not required to do that. They might just decide to use their own psychologist, which is more often than not what happens. An outside evaluation can be completed if provided by the child's insurance and approved by the social worker, although the assessments used, you just have to make sure it's the most current and recent assessment tools. Unfortunately, I've seen kids go to providers, get an assessment done, and then it's like an outdated evaluating form, and then the school won't accept it. How old does a child need to be? ADHD typically is not going to be diagnosed until the child is at least 5 years old. Trauma can be identified as early on as a baby.
No, for the IEP, because
Oh, yeah, IEPs. I've seen kids in ECAP or Head Start with IEPs, and that's preschool, 3 and 4 year olds. So as early on as 3 and 4. There's also now like free preschools, free developmental preschools, and not all schools, but a lot of schools. A lot of them were cut this last year because so many districts had budget cuts. But if there is a developmental preschool and your child qualifies, they should get an IEP through the developmental preschool as well. And then we want to look at what must the IEP include. And any modifications of what the child is expected to learn and know. So those are those benchmarks and goals to identify how they identify what services are put in place. It will identify how the child will participate in standardized testing. So will they get extended test time? Will they get seated somewhere where there's less distraction? Will they be pulled into another room with a paraeducator? Will they be given at least 48 hours notice to reduce anxiety? There's a lot of accommodations that can be put in place for testing. How will the child be included in gen ed classes and school activities? So they're gonna, in the IEP, identify what percentage is in gen ed and what percentage is in special ed. There's always going to be prior written notice. When the school wants to change a child's services or placement, they can never change an IEP without holding a meeting and giving prior written notice. This is to protect the child's rights. Typically, you'll receive this after the IEP meeting has occurred, sometimes before. A social worker must consent in writing for the school to evaluate a child and must consent in writing before the school can provide the services in an IEP. So this can be a really simple process though. It really, all it needs to look like is if you are communicating in FTDMs or meetings about the child that you have this, and this concern, and everyone's observing the same concerns, then you just ask the social worker, hey, can you send an email to the team at the school to request an evaluation? It doesn't have to be this big written out letter you have to wait weeks for, because we all know how busy social workers are. And then the caregiver and social worker can request a meeting at any time. So if you have an IEP in place, it lasts for 3 years and then they completely reevaluate again. And the minimum requirement is there's an IEP meeting once a year, although you can request a new meeting at any time. I have 2 kids with IEPs because they're neurologically diverse. One of them, earlier in the year, it was not cutting it. We had developed it. We had signed on the dotted line May 31st of last year. There was only 2 weeks left of school. Didn't get a chance to see how well it worked. A month into the school year, I was like, nope, this isn't enough support. And then 2 months in, we added some more, got to see if that was enough. I was like, nope, that's not enough support. We need to tweak it again. We ended up having 4 meetings before January, and that was okay. Now he's got his IEP outlined in a way that fits what his needs are. Don't always need to do that. It's just important that you know that you have the right to request that meeting anytime. Someone asked, what is the possibility of 2 boys with different fathers both having ADHD? My boys are 9 and 4. Will the younger get it also? High probability. It's just becoming so commonly diagnosed. I don't know what the exact statistics are, like 1 in how many, but it's becoming, it's like I said earlier, it's one of the most common diagnosed childhood disorders. Someone can outgrow ADHD, like they'll have it in childhood but not adulthood, which is different than someone who's not diagnosed until they're adult. And then you also have to keep in mind that kids exposed to trauma early on are at an increased risk of developing ADHD. And you have to keep in mind if there was substance abuse exposure in utero, also are predisposed to ADHD. So there are certain risk factors for kids in foster care that automatically there's an increased incidence of ADHD. And ADHD and trauma present so similarly, sometimes it's just really hard with these kiddos specifically to identify which is which. So I would love to hear if anyone here has a child that has a 504 plan or an IEP. Do you feel like you understand it? Do you know how to use it? Do you have any questions about that?
Yeah, this is EC. Our kiddo has had an IEP since like, was it midway through kindergarten?
Yeah.
And so we went through the process of getting it. It's been hugely helpful, I think, partly just because there's so much just attention and having everybody in the room and having the principal there. And, you know, so that's been really helpful. And our special ed team is great. And so, you know, that I think it's been really outstanding for us. It was a little bit of an effort to get it, but once it was in place, it's been really helpful. I would say that he qualified for social emotional learning when he was in kindergarten. And I think partly that's because the academic is a little harder to kind of even talk about at that age, but they've been a little resistant to adding the academic to kind of the list of what's going on with the IEP. But then he still gets all of these supports anyways. And so we're at a school where they have, I think it's called a multi-tiered support system, MTSS, which is awesome. But they were kind of resistant to adding the academic to it, even though we're seeing academic, you know, he's behind in reading and and math and all of that. So I don't know, that's the one thing where I think we still need to kind of work on it a little bit, but we've been pretty happy in general with the process.
Good. Good job advocating to get that put in place. And I agree, one of the huge benefits of a 504 and or IEP is that you have this team that's there to support the child and your family. Similarly to how you have your FTDM team, right? And so that can be hugely helpful, just a lot of different perspectives and resources and support. It's not uncommon for schools to want to wait to put in those academic goals into an IEP. A lot of times I'll see that a child has to be 2 years behind. And you can continue to be making those requests. Like if you're consistently getting stuff sent home from school that's documenting concerns that he's behind academically, then I would suggest at the end of the year, making another request for an evaluation for math or reading, writing, whatever the area is that you want. They can, even though they do a full evaluation every 3 years, you can request a new evaluation in certain areas at any point.
Can I ask a follow-up question on that? Because, you know, they're doing all of these evaluations, but the way they express it is usually as, you know, percentage or percentile, like he's, you know, 20th percentile in reading and, you know, compared to the peers, right? So can you give me like the 2 years behind is super helpful, but is there any other kind of benchmark of like what percentile, how low it would have to be before they're starting to say, hey, there's a need for academic supports beyond to add that to the IEP?
I have read hundreds and hundreds of neuropsychological evaluations that kids have had. If a child is 18th percentile, 20 to 18th percentile or below, this diagnostic evaluator is going to recommend intervention through an IEP. So 20th percentile is right there, like right there. I would be requesting another evaluation. And I would also ask that question, at what point do you think he should qualify for additional support? Sometimes what'll happen at schools, if it's a Title I school, is they'll do those pullouts as a way to provide that support without documenting it and having it being required the way that it is in an IEP and special ed services. That's another important piece of information to gather. If they're getting those pullout services, that's documentation that they're needing additional support, and you want to formalize it in the IEP.
Okay,
Does that
yeah,
help?
that's really helpful. Thank you.
So
Emil,
with-
I have a question. We deal a lot, we have 2 kiddos that have an IEP. We keep getting told we're going to do this RTI, the response to intervention, but we're not making progress. So do you have any tips on how to work through that?
I haven't heard that term, response to intervention.
Yeah, so I guess it's utilized. What they're saying with one of our kiddos is that based on missed instruction, he doesn't qualify for an IEP. So they want to try this response to intervention. And our
Okay.
experience with it has been 100% failure. And that's across like an 8-year period with multiple kiddos.
Yeah.
So we're just a little bit lost on how do we move forward when this district is so resistant to putting that specialized.
What was the cause of needing all of that missed school?
Well, so I've specifically asked them, what missed instruction are you talking about? And they won't provide that information to me. So if I
The
look at
school or the
attendance,
social worker?
so in our instance, we're relative caregivers, so adoption is actually finalized. So the school is not providing it to us.
Oh, interesting.
It's been a very big uphill battle.
Yeah, so at that point, I would make a formal request to they by law should require provide you with that information. So I would make a formal request to the school team, including the special ed director, and then if you still don't get that information, then I would go through OSPI.
Okay,
OSPI
perfect.
has parent advocates that will intervene if things are not happening that are supposed to. And there's a timeline of when they're doing, I don't remember what you called it, but I know what you're talking about. I just haven't heard it called that. There's a timeline that's supposed to be given of how long they do that intervention technique before they have to implement an IEP.
Okay,
So,
wonderful. Thank you.
yeah, documenting everything in writing is going to be so important though.
Yes, we definitely do that.
Yeah. I'm hoping this next slide might be helpful for you too, though. So then we want to think about how do the schools evaluate the kids and how is that different from an external evaluator? And how do they diagnose? So schools don't evaluate for specific diagnoses. They evaluate benchmarks. And they do not diagnose, they cannot diagnose. They cannot provide your child with a diagnosis. They establish if there's interventions and or accommodations that are needed and what level, and then they add in the specialized instruction that's needed, but they will not be able to tell you, oh, your child has dyslexia, oh, your child has ADHD, oh, your child has autism. They can't do that. Educators from the SPED department can be used to evaluate such as speech and language pathologists, occupational therapists, and school psychologists. Oh, thanks, Luann. They're going to look at standardized test scores, samples of a child's work. Teacher and caregiver feedback are also used to evaluate. There's no guarantee that the evaluation is non-biased based on the funding, staffing, culture of that school, and the personal opinions of that school. This is where it gets really tricky, especially for foster kids, because as you may know, there can be some biases against foster kids or kids in general that just have behavioral issues that they just need to get it together, and they're just not trying hard enough, and just this really negative impression of how these kids should behave if they try harder, things like that. And so that is definitely one of the downfalls of letting the school evaluate. Areas that the schools can evaluate are on adaptive, social and emotional, externalizing problems, internalizing problems, school problems, verbal and nonverbal language, or knowledge, excuse me, which is their cognitive function, math concepts and application, math computation, math fluency, language composition, written expression, spelling, writing fluency, fine motor and visual skills, planning and self-monitoring. And another one I want to mention is organization, because that is something that plays a huge role with trauma and ADHD. So those are the primary things they can look at evaluating. There's other things they can add in, like the organization. If a child has often changed schools, which can be really common for these children, or has low attendance, like someone just mentioned, it can lead to poor data for evaluations. And so what might happen there is they take a let's wait and see approach, or let's do some small pull-out interventions. And meanwhile, oftentimes what can happen is it's not enough because they have specific needs that just aren't being met. And they have needs that need specialized education. So what can an external evaluation provide? So it's going to be your unbiased evaluator. They don't know you, they don't know your child, they're just there to evaluate. They're going to assess the IQ, which very much impacts function of a child in school. You're going to get the diagnoses. That is so crucial to have a name for why you're struggling with something. Someone earlier just shared her experience with being diagnosed as an adult with ADHD. It puts a name to it. It can oftentimes be comforting. There's this old mentality that we don't want kids labeled, and we don't want that stigma. But that's going away now. The more information, the better, to help a child understand their function and help others understand their function. Whenever you get an external evaluation, they will always list off recommendations and a full report of resources for the caregiver. They show standard deviations. So what that means is they'll identify, here's the child's IQ, here's where the child is functioning, and this, that, and the other area, such as processing speed, reading, writing, things like that. And if there's a gap in their ability and where they're at, that's the standard deviation. How many gaps between ability and where they're at. And the goal is to have those come together as closely as possible. So we want to assess more of the child's, they will assess more of the child's whole story that you can provide. They'll look at the birth history if known, sleep history if known, trauma if known, family function, family history. Like I mentioned earlier, only recommend using a psychologist, psychiatrist, or neuropsychologist for these types of evaluations. And then again, making sure that the testing methods are accepted by the school. And my agency does family preservation for a lot of family preservation services for a lot of families with kids. And we have a pretty good success rate of finding evaluators that do take state insurance. I know that they're out there. Recommendations for 504 and IEP is get as many things in writing as possible. If something is not on there, it may not happen no matter what the school promises. I can't tell you how many times I've sat in on a meeting and the school says, oh, that teacher they have, they're so good at that. You don't need to bother putting that in there. And I always counter with, what if the teacher dies? What if the teacher quits? What if the teacher moves? It needs to be on the document, or there's no way to promise it's going to happen. Or if there's a substitute, or if the child transfers to another school. Because that IEP and 504 goes wherever the child is. It's not school specific. You want to add in as many accommodations as it takes to get the child's needs met. Doesn't matter if it's laundry list. Like I've seen some IEPs that have 20, and that's okay. Make sure that all educators have a copy of the document. Do not assume anyone has it. This really, what I'm speaking to here is when children are in middle school and high school, you just want to check in with every single teacher. Do you have a copy? Do you have a copy? Sometimes they don't get it out. Schedule a meeting with your child's social worker and other team members, such as a case manager if you're lucky enough to have one. With the teacher at the beginning of the school year to go over the 504 IEP, frequent check-in. And this is different than that once a year IEP meeting. This is like a beginning of the year check-in because you're the expert of your child. Frequently checking in with the educators, be the expert of them and partner with a teacher. And then ways to help at home. Again, be familiar with that IEP or 504 if there is one. And in as many areas as you can, if there's things you can do at home that are on the IEP or 504, carry that consistency into the home. Become familiar with signs and symptoms of ADHD and trauma so that you know to not take it personally. It's so easy with the behaviors that come with ADHD and trauma to take it personally, to think, why are they doing this to me? Or they need to get it together. There's no control over these behaviors. We can teach them impulse control, we can teach them skills, but it takes a lot of intentional effort and intervention, and it's very hard for them. Reward systems and incentives are hugely helpful, specifically for the ADHD. Keep them up in a few different areas of the home for visual reminders. I know that Luann has mentioned a lot of different trainings on the Alliance website on topics like this. ADHD and trauma both result in short working memory. So short working memory is something like if you say to your child, go brush your teeth, and then they see Play-Doh on the way there and they get distracted and they want to sit and play with the Play-Doh and they forget about brushing their teeth. That's that short working memory. They forgot they're supposed to go brush their teeth. Rewards can be really helpful for things like that. Make sure to give yourself time out, give yourself rewards, and give yourself grace. It is harder to parent children that have ADHD and trauma, period, end of story. That is a reality. It is significantly harder than parenting neurotypical kids and kids that have not experienced trauma. Make sure to rely on your team of experts. Don't try to do it all yourself. Take a parenting class that specifically is to support children and caregivers of children with ADHD. If your child has trauma, then you will get the same benefits. So I'll talk about this a little bit. Find ways to recognize more ways to praise your children. So typically kids that have trauma and ADHD need more commands to get things accomplished. They have more behaviors that you can criticize. And over time, that really can start to affect their self-esteem and their self-worth and your relationship with them. So challenge yourself to look for as many positive things as you can and say them out loud. And then we really want to be taking a multi-systems approach. And keep in mind, there is not a single intervention or support that treats ADHD and or trauma. There's just not. We want to look at all of these different areas to do that wraparound approach. So we want to support a child with therapy and or having therapy provided for the caregiver. We want to get support in partnership with the school. We want to consider medication management or working with a naturopath with supplements. That's a very personal choice. I'm not saying going out and doing that. I'm just saying these are examples of multi-systems approach. Making sure you're getting support as a caregiver from your partner, friends, family. Hopefully you have good case management, although that seems to be going away. Having good peer support for caregiver and the child. So if there's any kind of support groups or after school activities or, groups that you or the child can join to meet, like foster parent nights. Those are great peer support activities for you and the child. Have healthy stress outlets for you and the child, proper diet, sleep, nutrition. Those are crucial, critical for kids that have ADHD and trauma. I just can't emphasize that enough. I would love to know, what do you wish someone would have told you that you now know about children that have trauma? In the very beginning, what do you wish you would have known?
I think this is EC again. One of the things that you already mentioned, but I think is just hugely as important, is just not taking it personally. They're not doing it to you. They're not able to control the reactions that they're having. And that's just so hard. But as a caregiver.
Yeah, it's so hard. I really appreciate that. Keep in mind too that their prefrontal cortex, the part of their brain that is in charge of their reasoning, their judgment, their impulse control, it's not fully developed until 25. Anyone's prefrontal cortex is not, and actually I think it's a little bit later for people with ADHD and trauma. And people that have ADHD, their prefrontal cortex develops slower and it doesn't function as well as someone that doesn't have ADHD, and trauma presents very similarly. So one helpful thought can be that my brain works better than theirs. And in a very literal sense, my prefrontal cortex works better than theirs right now. Just reminding yourself of that. Does anyone have anything they could share that has been helpful for you to support a child who's experienced trauma that might be helpful for another parent or caregiver?
So I am a person who has both trauma and ADHD. And I find that I was forgetting to, like, because I work from home. So brush my teeth, brush my hair. So if I set up my environment so that I go to the bathroom and I come through and to wash my hands and my brush is there, my toothbrush is there, that the environment itself is reminding me what I need to do. When I get to work, at the top, I write these cues of the tasks that I have to do through the day. And those are things that help me be successful at what I do. So, I mean, those are things that I can put out there, and it just, and I remember people asking, and I used to ask people too, are you numb? I mean, if you're numb, you don't know that. If your trauma has been so bad and you don't know, and you don't know what's normal. So, yeah, that's a hard thing.
Thank you for sharing that. That's so helpful. What you were just describing is called habit stacking, where you're placing one thing by something else to remind you of somewhere that you're already going. So that could be a great tool to use with kids too, if you're trying to implement something new into their day, like a medication or whatever. Habit stacking is a great tool. And like you mentioned, normalizing just how some of the trauma affects the function. Okay, I'm going to go through these resources. So there's a book called Smart But Scattered, and then there's a Smart But Scattered for teens. 10 out of 10 recommend these books if you have a child with ADHD. They're so helpful and thorough. The website understood.org, it gives really concrete, easy to understand information about neurological differences, how laws pertain to school. All of you should know that you can request from the social worker to get an evidence-based parenting class that the department will cover for free. So the Incredible Years is one that is research proven and supported to work well with kids that have ADHD and conduct disorders like ODD and also autism. You also qualify for family preservation services where someone comes into the home and they can provide some additional parenting support if that's something that feels like it sounds better. Triple P is another evidence-based parenting program that would be helpful for ADHD, also PFR, promoting first relationships. And then Treehouse educational advocates are in regular contact with schools and students. If a youth on your caseload needs a phone or tablet to continue with an online educational program, they may be able to help with this. And then here's some resources through the Alliance. So topic group Education Resource Wednesdays. Here's one on March 20th on equitable access to education for Black, Indigenous, and students of color. That sounds wonderful. Watch previous recording on Treehouse. There's a class on ACEs and how that plays a role in a child's function pertaining to trauma. And then there's going to be a more, from what I understand from Luann, a more in-depth class on ADHD on April 16th. So those are some resources through the Alliance. See, there's a chat. Kathy said we use a number of visual cues and reminders that I can guide the kids so I don't have to manage every step or chores or other items. I love that. Yeah, if you can use visual reminders, those help reduce the number of commands given. But I would strongly encourage you guys to look for some evidence-based parenting programs through your social worker that you can get for free. They come to your home or you can sign up for an online one. My agency is going to be starting an online group for parents that have kids ages 3 years up to 9 on March 15th. So you can attend that for free, get lots of hands-on tools and support. And that is the end of our presentation.